Albuquerque, New Mexico. Just a caveat, it is raining, which is wonderful, but it also means that my internet has been unreliable all morning. So hopefully it will hold for the next 30 minutes or so as we sort of go over the presentation for today, which is details of formulation and dosing of buprenorphine. No financial relationship, no disclosures to make financially regarding the topic of this presentation. And I always like to point out that this was actually used to not be a core topic that we did. But very early on, when we started doing this echo, one of our echo participants actually from rural New Mexico really requested a presentation that went into kind of the very specifics, kind of he called it the nitty gritty of dosing of buprenorphine. And that's really how this presentation kind of came to be. And it's evolved over time. And I think it's actually, even as we speak, it's being revised. So hopefully in the next couple of cycles, there will be a revised version of this once more. But regardless, the objectives remain the same or very similar, right? We start by going over different formulations of buprenorphine. And then want to really go into spend a lot of times talking about sort of induction protocols. How do we start buprenorphine? Learning about dosing, duration of maintenance, kind of very specifically talking about formulations and dosing is what we're going to try to accomplish. And we're going to start with a little note on formulations. This is just a summary slide of many formulations of buprenorphine that are available. And it's really meant to highlight the fact that there are so many of them on the market, right? Starting with parenteral buprenorphine, which of course none of us are going to use if we're using buprenorphine to treat substance use disorders or even chronic pain. However, the parenteral formulation is used in emergency department or inpatient settings. In fact, interestingly, the first documented use of buprenorphine in the United States is the use of Buprenex, the parenteral IV buprenorphine, to treat acute pain in the emergency department setting. There is also the transdermal patch called the Butrans patch, which is approved for treatment of pain, but not for the treatment chronic pain, but not for the treatment of substance use disorders. Similarly, there is a low-dose buccal formulation called Belbuca, which is used for treatment of chronic pain, but is not approved for the treatment of opioid use disorders. All the rest of the ones listed here are approved for treatment of opioid use disorders, right? Notably, and just kind of breaking it down a little bit, right? So notably, a couple of things here. The implant, which is listed here, while it is FDA approved, it is no longer available on the market because no one was using it. So the drug company said there wasn't enough profit in it, so they no longer manufacture it. So it is no longer available. It used to be an implant that you would do a minor procedure and put under the skin, almost like birth control, and it would remain active for several months, releasing low levels of buprenorphine for about 6 months. What's not listed here, and that is my oversight here, is the subcutaneous long-acting injection of buprenorphine. Which is currently available, and we have many patients that we use it on. It's an injection given subcutaneously in the abdomen once every 4 weeks. Other forms of a similar long-acting buprenorphine are about to hit the market in the upcoming year. So we're going to have even more options coming up. So this is quite a busy chart, right, that we talked about. So this slide just goes into it in a little bit more detail, hopefully giving some practical tips on how do we pick between formulations of buprenorphine and naloxone. So first take-home point, right, is that as much as possible, the standard of care is to use the combination medicine. There is also buprenorphine monoproduct available, which is just buprenorphine without naloxone added to it. It's available as tablets. However, we only use it during pregnancy, right, during active pregnancy, and if someone has a documented allergy to naloxone. For everyone else, the recommendation remains to use the combination medicine because the combination medicine is less reinforcing and is also less prone to misuse through a parenteral or injectable use. And therefore, it is less likely to be diverted. So from a diversion management standpoint, it certainly makes sense to use the combination medicine as much as possible. More and more centers are starting to use the combination medicine even during pregnancy. And the early data seem to be that it's just as safe in pregnancy as it is, outside of pregnancy. However, the standard of care and the national recommendation remains to use the mono product, the buprenorphine mono product, during pregnancy. During breastfeeding, post pregnancy, it is perfectly okay to go back to the combination medicine. Now, the combination, there are three main formulations that we encounter, right? Simplifying this large chart, there are three main formulations we encounter. One is the sublingual film, which has buprenorphine and naloxone in a ratio of 4:1. There is also a sublingual tablet that comes in the same dosing, but also under a different brand name in a slightly different dosing, right? And there's generic tablets of buprenorphine naloxone, in the 8/2. I can tell you that usually in the state of New Mexico, what we wind up using more often than not is the combination sublingual film, which is available as a generic because most insurances, including Medicaid, will cover it, and most pharmacies tend to stock it. But there are other options, and they all are about equally efficacious, right? So between film and tablet, again, it's largely driven by third-party payer considerations and pharmacy availability insurance coverage. And in general, in New Mexico, we tend to go with the films. There is some idea that the film dissolves quicker, although it's not been evaluated in very controlled great studies. And also the fact that film comes in individual wrapped, applications. There's this idea that there might be less diversion. You can track it easier, right? I know some clinicians who are saying why we should be using a lot more injectables, right? And there are some real benefits to the injectable. For example, right, compliance, you don't have to worry about it. Someone comes into clinic once every 4 weeks, they get an injection, and you don't have to worry about adherence, right? Also, you don't have to worry about diversion. So those are some benefits of the injectable formulation of buprenorphine. But keep in mind that, first of all, the injectable medicine is very, very expensive, especially, if a person's insurance is not going to cover it. It can cost, $1,500 to $2,000 a month. There is also significantly less clinical experience and a closed distribution system. So to actually put everyone on injectable medication would be very costly and also may not be very convenient, right, for the patient as the system stands right now. But more studies are needed, more studies are being done, and I think this is going to be an evolving guidance. At our clinic, we've used the injectable in a few cases. One is, of course, continued diversion or suspected diversion of sublingual buprenorphine, despite doing all common sense things like monitoring more frequently, providing smaller quantities at a time, etc. We've also used it. We've had patients who were at risk, if they had their sublingual buprenorphine with them. For example, we had a patient whose parents said that the patient could not stay at their house because they did not believe in those medications, right? So the patient faced homelessness as a result of being on this medication, really driven by stigma. So we wound up switching the patient over to the subcutaneous long-acting injectable, and there was a way to ensure psychosocial stability for the patient. So use clinical judgment. Now, there are two forms of induction. And first of all, even as I start this section of the talk, I really want to kind of emerging idea. We used to use the word induction, that's still listed in all of these slides. However, more recently, we've started to move away from the term induction because there is an idea that the word induction makes this process seem tougher than it is, more complicated than it is. And it deters people and it kind of scares people off from starting people on buprenorphine. So increasingly, we are starting to say initiation, buprenorphine initiation, as opposed to buprenorphine induction. And we're actually working with PCSS to revise all of their slides from induction to initiation. So that should be happening, right? So that's one. Now, when buprenorphine first came out, the way we initiated buprenorphine was under direct observation in an office. And when we first started this echo, we had a whole section where we gave a process for home initiation or office initiation of buprenorphine. But more and more, the standard of care has become home initiation of buprenorphine. So I'm gonna go right into that. First of all, is home initiation safe? Is it effective? Is it feasible? And the answer is yes. In fact, what we know now from studies is that home initiation is just as safe and just as effective as a directly observed office initiation. On the flip side, patients like home initiation more. They're more comfortable, they're in the comfort of their homes, so they tend to prefer it. So more and more, we do home initiation for everyone except in certain cases. So that's what this slide is looking at. Consider, doing a home office induction, office initiation in certain patients. For example, patients who have low tolerance, patients who are transitioning from methadone, because methadone to buprenorphine transition is difficult and in many cases can lead to precipitated withdrawals. Patients who may have cognitive impairments, patients who may have untreated psychiatric conditions or certainly suicidality, or patients, we have some patients who are just so scared, right? They're afraid and they prefer the reassurance offered if they're in the provider's office. But for most everyone else, we at this point do home initiations without direct observations. So this is kind of the general strategy that we tend to utilize for home initiation. Everyone does it a little bit differently. This is, and my hope is just to give some general guidelines of it. So first, I tell patients to wait until they're feeling really lousy. I tell them, don't take it too soon. Otherwise it can make your withdrawals worse. We tell them the magic numbers. We tell them to wait at least 12 hours since the last use of short-acting opioids, and at least 24 hours since the last use of any long-acting opioids. And if they are doing a home induction for methadone, we tell them to wait for at least 48 hours before switching to methadone to buprenorphine. I send them home. When I give them the instructions, when I do this, I actually send them home with a copy of something called SOWS. SOWS stands for Subjective Opioid Withdrawal Scale. It is a validated scale of opioid withdrawal that is designed to be self-administered by the patient. And I tell them that you must wait until those magic numbers, then administer yourself the scale, and you want a target score of at least 17. 17 to 20 is generally a good, safe time to start buprenorphine. And once you hit that threshold, you start with a 4 milligram dose. I generally will call in a 2-day supply of buprenorphine, right? 2 or 3 day supply of buprenorphine. So they have enough. They start with 4 milligrams and keep repeating 4 milligrams every couple of hours if they have withdrawals for a total dose until they feel better or until they get to 12 or even 16 milligrams right on day 1. So we use that threshold of 16 milligrams for most patients and aim to get patients to that dose relatively quickly, within a day or 2 days at most. And we tell them just to give us a call. If there are any questions, if there are any problems, if they need any help, just give us a call and let's work through it, right? And this is an example of the Subjective Opioid Withdrawal Scale. As you can see, it's very similar to the COWS, the Clinical Opioid Withdrawal Scale, but it's sort of meant to be self-administered, right? I've experienced this. I have goosebumps. I have cold flashes, right? Things along those lines. Then on day 2, they take a total of day 1 in the morning, right in the morning, all at once. They call the clinic check-in. And later in the day, for example, on day 1, if they took less than 16, then on day 2, they can go up to 16 on day 2. And so generally, you're going to get them to that threshold of 16 within the first couple of days. In my experience, it's very rare for that initiation process to extend into the 3rd day, right? Because we want to get them to that target dose of 16 or less for some patients relatively quickly. And once you get that 16 milligram dose in general, we want to allow it to reach steady state by waiting about 5-7 days before increasing the dose further. So if patients get to 16, they've been at 16 for about a week, they're still having cravings or withdrawals, I'm gonna bump them up from 16 to 20 or even 24 milligrams, right? This is the magic numbers for reference, how long to wait that I've already talked about, right? Transitioning from methadone, I alluded to earlier, can be challenging. If you look at the literature on precipitated withdrawals, when people start buprenorphine, about precipitated withdrawal will occur in less than 5% of cases. And in a vast majority of those cases, it's when people are switching from methadone, which is when people tend to see it. So generally, we want to bring the methadone down to at least 40, even 30 milligrams or less for at least a week for allow it to reach steady state. Then you go without methadone for at least 48, even 72 hours, during which time we provide symptomatic management, right? Kind of adjunctive medications to treat their opioid withdrawal symptoms. And then only do we begin the process of starting buprenorphine. And very often, when patients are switching from methadone to buprenorphine, I tend to prefer doing it under observation, just for reassurance and just so we can be a little bit more aggressive with treating their withdrawals. But you don't have to do it in the office. What if precipitated withdrawals do happen, right? It's relatively easy to manage, right? First of all, I educate my patients about this possibility ahead of time. I tell them, please be honest with me about when you last used any opioids. And I'm only asking you that because we want to help you feel better, not feel worse. I also tell them that in case you do have withdrawals after the first dose of buprenorphine, stay with us. Don't run out of the office. We know how to treat it. Because the treatment is relatively simple. If they have precipitated withdrawals, you simply provide more buprenorphine plus minus symptomatic management treatment, right? And the idea is that you're providing enough agonism from buprenorphine to suppress the withdrawal symptoms and get them on a good dose of buprenorphine, right? So that's the idea. Now, not a whole lot of literature on it, but something that I would be remiss to not mention are what we're calling microdose inductions. I know there are several of you here, even in the audience. I know you're on, Dr. Singleton, and I know you're doing a lot of microdose inductions, as are several other members, right? There is not a whole lot of data, but increasingly more and more people are starting to do this, including us at the University of New Mexico, right? And the idea really is because you have some patients who are just going to be really reluctant to even be able to go to 12 hours or 24 hours without opioids to start buprenorphine. In my experience, it's most often the case with patients with chronic pain who are taking opioids to manage their chronic pain, and they're really worried. What is my pain going to be like as I go into withdrawals and as I don't receive my pain medications? In that case, we often opt for these microdose inductions. The idea is that the patient can keep taking whatever opioid they're taking, and you start adding on tiny amounts of buprenorphine to that, right? With the idea in a stepwise fashion. So the idea is that each day the buprenorphine displaces a tiny amount of whatever opioid the patient is taking. So over several days, as the dose of buprenorphine goes up, right, in actuality, there is less and less of the other full mu agonists binding their opioid receptors because buprenorphine has been displacing it, taking its place. And once the buprenorphine is at a stable dose, then they can simply stop whatever other opioid they were taking. So the key thing is that it does not require withdrawal from opioids prior to the initiation process. It takes advantage of buprenorphine's higher affinity at the mu opioid receptor. That's what allows it in a stepwise fashion to displace whatever other opioid, right? And the pre-opioid existing opioid may be tapered or stopped after the initiation. There are many different modalities out there that people are doing, people are looking at. Some use the buccal formulation, the low-dose buccal formulation as a bridge. Some use the transdermal patch as a bridge. Some do a combination of all of them. This is sort of the classic way of doing it, right? Which is called I guess people are calling it the modified Bernese method. Where, so say for example, I'm taking oxycodone 10 milligrams 4 times a day. I'm too afraid to stop it, and I see Dr. Jacobson. Dr. Jacobson would keep telling me to keep taking my oxycodone while adding on small doses of buprenorphine. So on day 1, I may just take 1/4 milligram of buprenorphine. On day 2, I would go to 1/4 milligram twice a day. Day 3, that would go up to 0.5 milligram twice a day. Day 4, 1 milligram twice a day. Then 2 milligram twice a day, right? Then 4 milligram twice a day. And by day 7, I get to about 12 milligrams. At which point, she would tell me to just taper off of my oxycodone over about 3 days or so. And then she would titrate up my buprenorphine as needed until I have achieved good effect. So this is a good way, not a lot of controlled trials, but just something certainly to keep aware of, because it is a new trend, and it is, I expect that, it's going to be happening more and more. Some considerations on maintenance dosing, right? So FDA does have it approved up to 32 milligrams, but most insurances will only cover up to 24 milligrams. We used to say that there is little evidence in clinical studies beyond a 16 milligram dose, but some of the newer studies have shown that 24 milligrams of buprenorphine may lead to a better treatment retention compared to 16 milligrams. I suspect it may be because we're seeing more high potency opioid use. So maybe people are just requiring higher doses of buprenorphine than they used to. So we use it clinically, titrate to effect. I tell patients at the right dose, your withdrawal symptoms should be gone or minimal. Your opioid usage should be able to go down, and the craving should also decrease, right? And there should be no side effects. So okay to go higher, than 16 if you need to, right? What about duration of prescription? Another very practical question. In general, we want to tie the duration of prescription to how the patient is doing. And it can go both ways, again, depending upon the patient's stability and the response to medication. In general, we tend to start with weekly prescriptions for about 4 cycles, then go to every 2 weeks, then go to monthly. And for some of our many stable patients, we may do, who are functioning, who are working, who are going to school, maybe taking care of an elderly parent. We may even go to monthly with a refill, or even occasionally monthly with 2 refills, right? Diversion management, we have a whole talk on it, so I won't belabor the point. But, in general, right, just be responsible about it as much as possible. Use the combination medicine. Be sure to monitor the urine drug screens, their prescription monitoring profiles. Safe storage lock boxes, very important, along with occasionally random 48-hour callbacks. It doesn't have to be all the time, but maybe a couple of times a year, where you call the patient and the patient has 48 hours to come in, so you can count the remaining medicine. Maybe at that point, the patient provides a urine that you send out for buprenorphine metabolites, right? I know our time is about coming to an end, I believe, but I did want to mention a couple of notes on HPSOs, or high potency synthetic opioids such as fentanyl. In general, it seems, and this is, we don't have a lot of data on it, but some of the newer data is really supporting the idea that buprenorphine seems to be working just as well, just as well with fentanyl as it does with heroin, for example, right? And there was a study by Sarah Wakeman from 2019. Although anecdotally, people are reporting more precipitated withdrawals, but clinical studies have not bore it out. So people are taking different approaches, right, about how do you reduce precipitated withdrawal. So one approach is starting low, going up slowly. So instead of starting at, waiting until the cows is higher, waiting until the patients are at least in moderate withdrawals before starting buprenorphine. And instead of starting at 4 or even 8 milligrams, starting at 1 or 2 milligrams, and frequently redosing every 1 to 3 hours and building up. So starting low and going up and waiting longer. Some people are taking that approach. This was a study that came out not too long ago, just a case series, so not a great quality study, which showed some support for that approach of starting low and then building up. On the other hand, some people are taking the macrodose approach, right? And this was a study that again came out very recently. Everyone was using fentanyl, and what the authors did, this is Josh Lee out of New York, and what the authors did is that they actually built them up very quickly. The idea being that they're used to, so much mu-opioid agonism that our traditional approaches simply are not providing enough mu-opioid activity. And that's why people are experiencing withdrawals. So why don't we just build them up quickly? So what the authors did is very quickly started buprenorphine, 8 milligram dose, build them even up to 24 milligrams in a day, and then switching them right over to the injectable long-acting buprenorphine, which also releases quite a bit of buprenorphine very early. So there are different approaches. Again, there is no great data, nothing comparing one to the other, but I'm more including these slides because this is on the horizon. And I certainly would be remiss if I wasn't giving the preview of it. Finally, a little note on withdrawal and maintenance. Continue the medication for as long as it benefits the patient. We don't force patients to come off of the medication. We, caution them, in fact, from stopping treatment too early, because unfortunately, most people have a recurrence of use when they do stop. If the patient does wish to stop buprenorphine, if they're on it, what I tell them is the slower you do it, the better it is going to be, right? I educate them on risk of relapse, right? And I tell them that if we're going to do a withdrawal to give it best chance of success, ideally we should start the process when functional goals are met, when your life is more stable, when your social networks are more stable, and we do it at your own pace while staying engaged in treatment or 12-step groups, etc. And once you're off of the medication, think about switching over to long-acting naltrexone as an antagonist treatment, as a safety net, right? And that's generally my approach to patients. I will stop here in the interest of time.